and thanks to everybody for joining us today. It's really a pleasure to be able to speak with you about this topic. And I'm going to, first of all, see if I can pull up my slides. There they go. Hopefully you can see that. And we're going to go through a few things here about this issue of using big data to advance precision mental health. And I'll just start off with some disclosures so that you have those in mind. Okay, so let's get into it. The first point to make is the scale of the problems that we're facing in this field of mental health. And this is undoubtedly quite familiar to most people who are here today, that psychiatric disorders are leading causes of disability, that they are incredibly common, affecting more than half of us at some point in our lives, and typically onsetting early in life, so that people are living often with these conditions for a big chunk of their lives. We know that early intervention can be helpful, but we don't have a lot of tools to identify who might be at risk and sort of target prevention efforts. They can be lethal. As you know, people with serious mental illness, on average, can have anywhere from 10 to 25 years of shortened lifespan. Suicide, of course, is the second leading cause of death among young people. They're associated with tremendous costs, and almost all of the treatments, that, at least the medication treatments that we have, are based on mechanisms that were identified, decades ago. So that's a pretty daunting set of things to address. What I'm focusing on today is the notion of precision medicine and how that might impact psychiatry and mental health care. And precision medicine is a concept you may have heard about. This is a definition from the NIH Precision Medicine Initiative Working Group report a few years back, but it's a good one, I think. Precision medicine is an approach to disease treatment and prevention that seeks to maximize effectiveness by taking into account individual variability in genes, environment, and lifestyle. And I think the key term there is individual variability. It's about making use of the fact that we all differ in many ways. We're all unique. And we now have the ability to pursue this kind of approach because there have been, in part, just in the last 10, 15 years, the growth of a whole suite of tools and resources that we largely didn't have before. So one of them, of course, has been DNA and genotyping and sequencing on a large scale, but other omics as well. By other omics, I mean things like transcriptomics and proteomics and metabolomics, all of these data sources that give us other fundamental insights into underlying biology and individual differences. Many of these things are available through large-scale biobanks that are now increasingly widespread, many of them linked to electronic health records, which are themselves massive data sources. We've seen the advent of digital and mobile health technologies, smartphone technologies, and so on, that are getting more and more sophisticated, generating more and more data. And we've seen the progression of methods that are capable of really extracting meaningful information from these data, things like machine learning and other forms of artificial intelligence. We have new ways of generating phenotypic data from the molecular level to the circuit brain level, et cetera. And of course, we have clinical trials, which were there before, but we now have other ways of designing these trials that can make use of some of these data sources. So that creates a bunch of opportunities for what I'm calling, and others are calling, precision psychiatry. That is bringing this precision medicine approach to psychiatry. And here are just a few of the major opportunities I think we have to address some unmet needs. One of them is in the realm of diagnosis. As we all know, our diagnostic boundaries, our nosology, is based largely on a descriptive system of syndromes that's based on a consensus of experts. We now have the ability, or the possibility of using data-driven methods to sort of test those boundaries and say, what makes sense? And does it match what we see, for example, in the DSM? Risk stratification. How do we identify people who are at risk for various outcomes and then be able to target prevention or intervention strategies towards them? How do we match patients to treatment in a way that doesn't rely on the kind of trial and error approach that we still have? And then can we develop novel treatments that are more tied to the underlying biology, psychology, individual differences that are really driving these conditions? So I'm going to say a little bit about the first three. In the interest of time, I'm not going to get into the last one, but happy to do that another time. So let's talk about the nosology or the diagnostic thing. This to me is of course, fascinating area, as I imagine it is to many of us. How we define a psychiatric disorder, how do we define the variation between a disorder and, say, what we might call normal variation? One of the tools that we now have is an understanding from genetics. And we have been doing genetic studies for quite some time, and we have found a few things. One of them we knew for a while from twin studies and so on, that the major psychiatric disorders are heritable, meaning genetic variation or individual differences in our genes contribute to risk of these disorders. And you can see that in this little graph here. I don't know if you can see my pointer, if it shows up, maybe not. But you see the heritability, it goes from 0 to 1 or 0 to 100%. And those bluish bars are the heritabilities estimated from twin studies. So for example, for ADHD, you see a pretty far out there bar suggesting that maybe about 76 or so percent of the variation in risk in the population is attributable to individual differences in genes. Now we can start to measure those at a molecular level, this kind of heritability. The estimates are not as high, but they are still significant. And in the rest of this slide, what you're seeing is that we've seen just this tremendous acceleration of growth of actually identifying genetic variation that contributes to these conditions. Beginning around 2008, 9 or so, we have now identified hundreds, maybe thousands of loci, genetic loci, that are statistically very robustly associated with a whole range of disorders. And we're learning all kinds of things from this research, but the one I want to focus on for a moment is, what does it tell us about the underlying structure of psychiatric disorders? And again, we know that the DSM, our sort of canonical guide to making diagnoses, has been an evolving and somewhat moving target since 1952 when the first edition came out, and now at DSM-5, you're looking at the number of diagnostic labels in the book. Most of these things are sort of provisional, and they are our best convention for establishing a diagnosis. But we know that they are shifting over time. The genetic studies are actually giving us some fascinating insights here when we put together, again, large amounts of data. And through the Psychiatric Genomics Consortium, which is one of these very large genetic consortia of scientists from around the world, the cross-disorder group of this consortium has published a number of papers and studies addressing this on a pretty large scale. So how does the genome map onto psychiatric diagnoses? One of the things that's emerged here is that many of the conditions that we think of as clinically pretty distinct, for example, schizophrenia and bipolar disorder, which are actually mutually exclusive diagnoses, right? You can't give both. And they are thought to be, foundational diagnoses. At a genetic level, they are very highly genetically correlated. That is, many of the genetic variations that affect one are also affecting the other. And using a method, it's called genomic structural equation modeling, we can actually, and have now taken data across multiple psychiatric disorders and said, if you look at all these interrelationships, does it boil down to some fundamental structure? And what we see here is these four factors, latent factors, that if you put the data, genome-wide data, for hundreds of thousands of individuals with genome-wide data across, in this case, 11 disorders, you see four basic factors. We now, in a later study, have seen five, one more added, which is substance use, but some of them are about compulsive disorders, anorexia, OCD, Tourette, load on a factor, psychotic disorders, or maybe serious mental illness, schizophrenia, bipolar disorder, again, tightly associated, neurodevelopmental disorders, and internalizing disorders. So a lot of the genetic variation reduces in some ways to these latent factors. And they have very interesting properties. The loci, or the genes that have these widespread effects across our diagnostic boundaries, seem to begin to be expressed at relatively high levels around the mid-fetal period of development, and they stay pretty high. There's lots of other interesting insights into this, but one of the reasons that you might care about this is maybe it tells us something useful about developing treatments. And in this case, for example, we used an extension of that structural equation modeling, which is transcriptome-wide structural equation modeling, essentially mapping the genes that load onto these disorder factors, or these latent factors. And then by looking at their expression profiles, how they're turned on in various tissues, and we could then say, let's look at these transdiagnostic sets of genes for these now 5 factors, genomic factors. What are they doing? And do they match any known drug mechanisms of action? And in fact, we identified 466 genes in this way, and using bioinformatic tools could identify 39 potentially repurposable drugs that are already known that would be predicted to treat psychiatric disorders, including certain kinds of calcium channel blockers for the schizophrenia and bipolar cluster as well. So that's some of the potential value. The other is, again, getting a more fundamental look at the underlying structure of our psychiatric disorders. This is a heat map just showing you the degree of genetic correlation among disorders. So you see all the disorders on the left-hand side there. Imagine them also lined up on across the bottom in the same order. The bottom line is you see a lot of blue here. There's a lot of genetic overlap. And it seems to particularly cluster into a number of fundamental dimensions of psychopathology. I know Bruce was on, so this is, very much RDoc-like in the sense of looking beneath our, diagnostic categories to some underlying structure. Doesn't suggest that we need to throw out the DSM by any means at this point, but it is going to give us a window into what's going on, perhaps at a deeper level. Let's move on to the idea of how can you use data to stratify risk in a more precise way. And here again, I mentioned, we have now new ways of analyzing data that are potentially much, much more powerful when handling these very large data sets. And one of them, of course, is artificial intelligence, which, is ubiquitous in the conversation these days. But if you think about it, for a long time, we've seen this play out in our lives. Many of the companies that we interact with day to day, for example, Netflix or Spotify or Amazon, they want to know, what is it you want to see? What should we send you in your feed or recommend to you? And the way they do that is by gathering vast amounts of data on people's behavior, and then using that to predict future behavior. It's a pretty simple concept when you can do it, when you have that much data. But of course, we could apply that to healthcare settings in a similar way that might be quite useful. And one of the sources of this massive data that we have in our health settings our electronic health records, which of course are capturing all of the encounters that we have in the real world with healthcare. And they contain an ever-growing longitudinal resource of data. For example, in our Mass General Brigham electronic health record, we're talking about 6.5 million patients with about 3.5 billion rows of data, a massive amount of data. And the data come in a couple of large groups or types. One are what we consider structured data, like diagnostic codes and laboratory values and prescriptions. And the other, the much larger, are narrative text and notes that we write, or discharge summaries or radiology reports. Both of them can be leveraged for data and for analysis, which creates a remarkable resource of data. One of the questions that always comes up with this is, how good are these data, especially in a research context? And I'll just give you an example. Early on, we were doing some studies of the genetics of bipolar disorder, and we had trained algorithms, basically machine learning algorithms, to evaluate whether somebody might have bipolar disorder or might not, might be a control. And we trained a number of different ways of doing this. But to validate it, we actually had the algorithm determine who in the healthcare setting might have bipolar disorder, who might have who might not, or who would be predicted to be a control. And we also had invited in people who had a diagnosis of schizophrenia or depression, which are often in the differential diagnosis. And then we essentially had people come in and undergo a semi-structured, gold standard in-person psychiatrist interview using the SCID interview form with clinicians who were blinded to the algorithm diagnosis. And what you're looking at here, we did this for close to 200 patients, are the results. So when it says diagnosis over here, it means what the algorithm was. NLP refers to natural language processing. So it was actually also using narrative text in notes. And PPV refers to the positive predictive value, meaning if the algorithm said you had bipolar disorder, what was the chance that a psychiatrist using the SCID, blinded to what the algorithm said, also thought you had bipolar disorder? Same for the controls. Bottom line is, these algorithms did incredibly well. So, 80 to 86% of the time, these were different levels of the diagnostic algorithm. When the algorithm thought somebody had bipolar disorder, so did a blinded psychiatrist using the gold standard interview. When the algorithm thought that this person was unaffected, 100% of the time, a psychiatrist agreed using that interview. We also went on to do a genetic validation, asking the question, so if we have genomic data and samples from these folks, which we did, and we look at the genes, how similar are they to what we have seen in other big studies of the genetics of bipolar disorder? And the answer was the genetic correlation was very high, 0.83. The heritability estimated from the genetic data was identical to the traditionally diagnosed big cohorts, which you see in this table. So I think that addresses some of the concern that these are, not necessarily as good as data that we might otherwise get. But now with those kinds of definitions in hand, we can do interesting things that might be clinically useful. For example, predicting who might be at risk for the emergence of bipolar disorder. The average delay in diagnosis from the onset of symptoms to getting a diagnosis of bipolar disorder can be 6 to 10 years. And the longer it is untreated, the more it is associated with severe and recurrent mood episodes, more frequent suicidality. So in a consortium, which I'll come back to, called PsychEmerge, we took the algorithm definitions that I showed you before. We put together data across 3 of our health systems, Mass General Brigham, Vanderbilt, and Geisinger, and tried to develop models that could identify people who are particularly high risk of developing bipolar disorder. And without belaboring too much of the details here, we only are now using structured data, meaning things like ICD diagnostic codes. And the teams at each of these sites trained models using different kinds of statistical methods. So one was ridge regression, for those who know about this, random forests, a kind of machine learning, or gradient boosting machines. And then we tested each of those at the other sites. And the bottom line was that they performed quite well. What you see in this table is that AUROC, that's the area under the receiver operator curve, which is how well the model can tell, let's say, the cases or the people who become cases from the people who don't. How good is it at discriminating those? And those numbers are quite good. And the relative risks were substantial. So if you were in the top 1% of predicted risk, across these sites, you had about a 12.5 to, say, 19-fold increased risk of developing bipolar disorder in the near future. The problem that we have devoted quite a bit of attention, though, to is the problem of suicide, which, again, people here know well is a very serious and tragic problem, a lethal outcome for patients with mental health conditions and those without. And we've seen a 35% increase in deaths by suicide over the last couple of decades, even more so among youth who, again, for whom it's the second leading cause of death. We think that healthcare systems are a particularly important venue for bending this curve. And that is in part because most people who die or attempt suicide are seen by a healthcare provider in the month leading up to the event. Now, only about a third or fewer disclose their suicidality to healthcare professionals. And we know that clinicians are not much better than any of the rest of us at knowing who's really at risk, unfortunately. So one of the things that we began to do years ago now was to see, could we take the kind of approach I mentioned to you before of using these longitudinal electronic health records to provide some better information about who might really need help, who might be at risk. And in this initial study, we developed and validated a risk prediction algorithm in about 1.7 million patients. And the algorithm was able to detect 45% of all suicide attempts or deaths about 2 to 3 years in advance. So we were encouraged there that the AUC number is cut off there, but it was 0.77, I believe. We then said, would this work in other healthcare systems? And so we did the same approach in 5 other healthcare systems around the country and basically got the same results, which was, again, very encouraging. We then asked, how good or how accurate would an algorithm like this need to be for it to be cost effective to implement in primary care? And so we did a detailed economic analysis that essentially showed that for the kinds of performance these algorithms have, if you were to pair them with evidence-based interventions for suicidality, they exceed a threshold of cost effectiveness. That is, they would be cost effective to implement. And then with colleagues led by Matt Nock here at Harvard, we did a prospective study of patients coming to the emergency department who were seen in the psychiatric emergency department. And we asked clinicians, what is the likelihood, do you think, that this person might make a suicide attempt in the next month or the next 6 months? And what you're looking at in the top half of that curve is the table, rather, is the area under the curve. Remember, that's sort of a measure of how well the model discriminates cases from non-cases. The clinician predictions were not that good. And just to give you a sense of this, these numbers typically range from 0.5, which would be like your algorithm is a coin flip. It's really telling you nothing, up to 1, which it never is, really. 1 would be perfect prediction. So 0.7 to 0.8 or above is generally considered pretty good. We also then ran the EHR algorithm, and we ran it with a brief self-report measure that we gave at the point of care. And now you see at the bottom there, the areas under the receiver operator curve were quite good. But even more startling, I think, was the positive predictive value. So if you take the folks who were predicted to be in the top 10% of risk, 40% of them went on to make a suicide attempt in the next month, and nearly 60% by 6 months. And we thought those are really actionable numbers. And so one of the things we did was go on to build an app, a clinical decision support app that could be implemented and integrated into the electronic health record in real time to give this kind of information with some context to clinicians, to document also a safety plan and to suggest options for care plans. And I'm happy to say that through a grant that helped us launch the Center for Suicide Research and Prevention, we are just about to initiate a randomized controlled trial of this method, of this approach, in our emergency departments in a sample of about 4,000 patients who will either be randomized to have their clinicians receive this risk score at the point of care or not, and we will follow up and really determine, is this kind of risk information helpful in reducing and preventing suicide-related behaviors? Let me just mention another kind of approach where big data is something we're sort of excited about. And this brings me to this consortium I mentioned before, what we call Psych Emerge, which I have the privilege of co-leading with Leah Davis, who's now at Mount Sinai, and Chris Chabris, who's at Geisinger. And this is a consortium of investigators around the country and now with international partners to put together large amounts of data to address all kinds of precision psychiatry questions. And we now have access to data for about 29 million patients and about 2 million of them with genome-wide data. We have a privacy preserving federated strategy for analyses. And the network has already been very productive in generating insights that really would not have been possible before without these kinds of data, these kinds of tools, and of course, the talented folks who are doing the research. One of the things that we look at are big genetic data. And just to give you a 2-second reminder about what we think of as genome-wide association studies that we can now do, we can now say, if we want to know what's somebody's risk of schizophrenia, let's say, and we have a large sample of cases and a large sample of controls, we can genotype markers across the genome, and we can essentially say what variants across the genome are statistically associated with being a case that is more common in people who are cases than controls. And as I mentioned before, hundreds of these have now been found. However, on their own, they have a tiny effect. They explain a tiny amount of variation. The odds ratio, if you carry, let's say, any given risk variant that would be associated with that variant would be something like, 1.05, meaning you have a 0.05, 1.05 times chance of being somebody with schizophrenia if you carry that variant. That's not obviously that useful on its own. But one use is that you can sum these across the genome and create a polygenic score. That is a single score that is the sum of all these little variations. And that is very useful. It's normally distributed. It captures much more variation, obviously, and is a kind of an index of genetic loading for whatever trait it is that somebody has done a genome-wide study in the past on. Well, in schizophrenia, we know that these can be, moderate risk factors. So, for example, these are data from the Psychiatric Genomics Consortium that show that if you look at people in the top 10% of that polygenic score distribution and compare them to people in the bottom, they have about a 16-fold increased odds of having schizophrenia. If you take the top 1% versus everybody else, it's maybe more like a 5.6% increase. But you can see the distributions of these scores on that last panel is highly overlapping. I mean, these are not diagnostic tests. But one question that we wondered early on in the PsychEmerge consortium is, what about in the real world? I mean, these are based, at least at the time, were largely based on fairly rarefied, rigorous research studies that screen certain people in. They do 5-hour, interviews, et cetera. What about if we're thinking of moving anything like this towards clinical use, or what does it look like in a real world setting? And so one of the things we did was put together, again, data, in this case from 4 healthcare systems, Geisinger, Mount Sinai, Partners, now Mass General, Brigham, and Vanderbilt. And the bottom line was, we did see very strong statistical evidence that a polygenic risk score for schizophrenia is associated with schizophrenia in our healthcare settings. The effect size, that is the odds ratio, was lower than what we see in some of these research studies. One of the other things that you can do, though, is you can now, because you have electronic health records tied to genetic data, look at what else are these genetic risk factors associated with. And so what you're looking at on the right side of that is something that we call a PheWAS instead of a GWAS, a phenome-wide association study. So we take the genetic risk score, let's say for schizophrenia, and say what else in the medical phenome, in all of the areas of medicine, is being high on that score associated with. And so everything beyond that dotted line is statistically significantly associated with schizophrenia genetic risk. So a lot of it were psychiatric, mental health, and behavioral conditions. That's not surprising. We already knew there was overlap there. But some of them are not, and they're sort of interesting. Things like morbid obesity, palpitations, viral hepatitis, synovitis and tenosynovitis, inflammatory conditions. And we can say more about that, but it gives you a sense of how you can use these data in ways that give you new insights into comorbidities, perhaps. Another thing that we've been able to do through this network, building on the work of our colleagues at Vanderbilt, Leah Davis, this is work led by Julia Seelock, was to take polygenic risk scores and make use of the big data that's available in laboratory values. So if you think about it, when patients are seen, or any of us go to the doctor and have blood drawn for labs, that's a set of laboratory values. And as you might imagine, there is a lot of data on that in the electronic health record. Could that be a source of getting clues about the biology of conditions and maybe new biomarkers? So in this case, what we did was took a polygenic score for depression, scored everybody on that. And we had data, again, from multiple healthcare systems. You can see on the right-hand side. And the question was, if you put all the lab values that have sufficient data into the analysis, what is a polygenic risk score or genetic loading for depression associated with? And the way you read that graph on the left, the y-axis is a measure of the statistical significance. So it's actually minus log of the p-value. So 5 on that y-axis means a p-value, statistical threshold of 10 to the minus 5. And that red line under there would have been the statistical threshold correcting for multiple testing. Anyway, what you see is one lab standing out above all others, and that was white blood cell count. And when you see on the right-hand side, across 4 healthcare systems and in a meta-analysis, the effects were rather uniform, really pretty strikingly similar, of this association between genetic risk for depression and white blood cell count. And these are not pathologically high white blood cell counts, but it's indexing something linking the genetics of depression to this measure of whatever you want to call it, inflammation or immune activation. And that's really interesting because it, again, is consistent with emerging theories about the role of neuroinflammation or immunity or immune activation as a contributor to depression. Let's talk about treatment, which is something obviously we all care about. And we have to admit that What we do now is still mostly one size fits all trial and error, which means that people often wait months, especially with medication treatment, to see whether something might work for them. Can they tolerate it? No, let's go on to the next thing. That didn't work. And it can turn into weeks, months of inadequately treated depression, for example. If you look at the data on antidepressant effects, they are shockingly modest. In meta-analyses, the mean drug advantage versus placebo has been estimated at less than 2 points on the Hamilton D measure of depression. That is not considered clinically meaningful. But we know that's not the whole story, because we know that some people do remarkably well, some people don't, and some people, can't tolerate the treatment. And that's, again, where this kind of precision notion comes in, the individual differences, the heterogeneity. And that's been supported by, analyses of treatment trials, for example, of antidepressants, where you see different distributions of response. And so we have, again, just to give you an example, taken an approach of, could we learn something that would help clinicians make a decision about what treatment to start with, for example, in an antidepressant treatment situation. And this was work led by Ihan Xu in our center, looking at electronic health record data from more than 17,000 patients who were started on one of the 4 arguably first-line treatment classes for depression: SSRIs, SNRIs, bupropion, or mirtazapine. We had lots of data, and we built these various machine learning and artificial intelligence models to see how we could do. Now, our prior probability, if somebody is coming in to see me, based on STAR-D and other studies, the chance that somebody's going to respond to any one of these 4 options is about the same. It's about, 47%, call it 50%. I don't know ahead of time. So if I have 2 patients, Tom and Megan, it's kind of a wash in terms of what I think they're likely to respond to. When we built and trained these models, we found that the models could correctly predict response for about 3/4 of patients. And these are data for 2 real patients from the data set. Obviously, their names are not Tom and Megan. But what you see is the predicted response to an SSRI for Tom was 94%, which is great. But for Megan, it was only 28%. But even better, and perhaps more clinically relevant, is, so what should you do if somebody's predicted not to respond well to something? And that's the advantage of these models, is that we can build them in ways that tell us what is the likelihood that one would respond to any of these 4 classes of meds. So as you see, it turned out for Tom, he would have done pretty well on all of these. For Megan, she actually would be predicted to respond best to mirtazapine, which might not be our first choice. She wasn't going to do as well on any of these classes of medicines, but the data would suggest that mirtazapine was the best first choice. Okay, let's go on to the idea of prevention. We're not terribly, we don't have a lot of great options in clinical practice for prevention. If you think about preventing mood disorders, what can we do to tell people to prevent the onset of depression, let's say? Well, don't have affected relatives, because family history is a risk factor. Don't have a difficult childhood or have childhood adversity. Don't use drugs. Unfortunately, those are not super actionable. There are a couple of things with increasing evidence that seem to have potential preventive effects on the development of things like depression. And one of them is physical activity. Physical activity has been associated with improvements in depression and maybe reduced risk of developing depression. And in this study, and a series of studies led by Carmel Choi here, we used a method that leverages big data, genetics, and causal inference. It's called Mendelian randomization. And it's a way of kind of using genetic variants to mimic randomizing people to higher or lower levels of an exposure, which allows you to make more of a causal inference. And in the interest of time, I'm not going to go into the statistical the statistics behind it, but I'll tell you that in data from the UK Biobank with, like 100,000 or more individuals who had accelerometer objective measures of physical activity, we could look at, is there a causal effect of physical activity on reducing the risk of depression? And the answer turned out to be yes, we did see evidence of that, a 25% reduced risk of developing incident depression with physical activity. And the level of physical activity was not huge to get that kind of an effect. You could substitute 15 minutes of sitting with 15 minutes of running, let's say. We then did a follow-up in our Mass General Brigham, or formerly Partners Biobank, where we again found higher levels of physical activity, lower levels of developing depression. And on the right side, we also had genetic data. So we could say, well, what if you were at high genetic risk or low genetic or medium genetic risk? Turned out that physical activity was associated with this protective effect regardless of your level of genetic loading for depression. So really, this is an intervention, if you will, or a lifestyle intervention that could be useful very broadly. The other area that has shown evidence of being protective is social support. And these are data from a study we did as part of the Army STARS program, looking at soldiers who were deployed to Afghanistan and looking pre and post deployment. So it's prospective. We actually had genetic data, and we could again calculate a polygenic risk score. And we found, as you see in the panel A there on the right, the higher your genetic risk for depression, the more likely you were to develop depression when you returned from deployment, in a pretty stepwise or dose response way. But the other thing we were interested in was unit cohesion, which is a measure of this kind of social cohesion among units in the military. And it's a very powerful phenomenon. And in fact, we saw that it was protective against developing depression, pretty potently in this case. But even more interestingly, if you had high unit cohesion, you did not have an increased risk of developing depression, even if you had high genetic loading, and even if you had high levels of deployment or combat stress. In another subsequent study, we've seen this protective effect of social support again. These are data from the All of Us research program, in which we have data from about 70,000 participants. This was early during the COVID pandemic. And the participants were asked in part about depression and about social support. And the bottom line here, again, looking at incident development of depressive symptoms and suicidality, social support had a powerful protective effect, a 55% reduction in the odds of developing incident depression. And if you had the three types of social support that were measured here, tangible support like financial, or emotional informational support, or positive social interaction, those people who had all three of those had an 85% lower odds. And finally, when we looked across the UK Biobank, one of these very large data sets, and identified 105 different potentially modifiable lifestyle and behavioral factors, and again, looked at what seems to be protective against developing depression, the thing that was the most positive was frequency of confiding in others, a measure of social support. But we took all the ones that showed promising effects in that association, and then we again did this Mendelian randomization to say which ones do we feel pretty confident have a causal impact: frequency of confiding in others, frequency of family and friends visit, and exercise. Really the standouts there. So just to sum up, we have, through the advent of large data sources and new tools that we really didn't have before, an ability to leverage big data to advance precision mental health. And there are a lot of things that we need to do better with, obviously, in diagnosing and treating and preventing illness. We have a center here for precision psychiatry, and we say that our emphasis is on innovation to implementation, shortening that journey from research discovery to actual practice-based implementation. That is the work that we're doing in suicide prevention, for example. And as we decide what we want to focus on, that is always the kind of guiding principle. Where is the path to something that can make a difference to patients, clients, families in the near term? We're going to need even more data. There are lots of limitations of the data that are available now. For example, in the genomics world, much of it is based on people of European ancestry, which is not most people in the world. There are limitations of missing data and electronic health records, et cetera. But this is really kind of a new window into making some progress in real world settings that may have value for us. And it's another area where this notion of implementation science becomes very important. It's an area that's relatively young of how do you actually implement these things and bring them to clinical care, and might be a topic for another webinar, but I'm going to stop there so that we have time to take your questions. And I want to thank everybody again for joining us.
Well, and thank you. We have 3 questions in the Q&A.
Great. So what's loci and SNP? Thank you for asking that. Okay, loci is, we think of a genetic locus as a specific region or gene in the genome. So often it means a gene, but sometimes it could mean just an area of association. SNP is a single nucleotide polymorphism. So that's the most common kind of genetic variation in our genomes. We all have millions of these in which, you might have an A and I might have a T in my genetic sequence. So that many of these are very common, and those are the ones that we look at in these genome-wide association studies. So when I say we've identified hundreds of loci or thousands of loci or SNPs, that means hundreds or thousands of genetic variants in the genome. Okay, next one. I'm struggling with this issue. The use of the term precision requires precision not only in analytics, but in required data inputs and outputs that describe context, non-medication treatments, persons, and outcomes. How do you suggest we deal with what is the shocking lack of precision in these areas that are common in mental health, but not in most areas of medicine? Great question. Totally agree. What we can do with the data are only as good as the quality of the data. And we always are mindful of that when we are reporting studies, because it's really important to know the limitations. It is true that I think in our area of mental health, contextual kinds of factors are perhaps more important than anywhere else. People live in social settings, they live in family settings, their finances, social determinants of health are crucial. Now, they're really important in other areas of medicine as well, and they're not well captured in any of those areas. So that's a problem. There are some specific problems when it comes to things like the electronic health record. Frankly, those of you who are clinicians will know and use the EHR that they have themselves evolved, that is the records over time, much more templated kinds of notes. They are often derived for billing purposes and not for explicitly research purposes. We are getting increasingly sophisticated, I think, about how to address some of those limitations, but they are limitations, and we need to be mindful about that. I think that in terms of what could we do to make it better, one thing is for clinicians to be better at and have more opportunity to document social determinants of health, for example, in the electronic health record, for us to be able to link data sources as is increasingly possible. I'll mention that the All of Us research program, which you may have heard of, this very large landmark longitudinal cohort study, has gathered very extensive data of multiple types: electronic health records, surveys, mobile sensor data, genomics, et cetera. And with surveys of, social determinants, et cetera. So we're very hopeful that that will be a platform that can begin to answer some of these gaps. And I encourage people to have a look at that. If you're a researcher, you can access those data typically. And it's really a remarkable study. Protective effects for anxiety disorders. Great question. There are some data similarly that social support and physical activity can be helpful in prevention of anxiety disorders. There are, more intriguing kinds of issues, and one of the things that we and others are looking at now is early exposure and screen time, exposure to screen time, and the social, which is not unrelated to social connection or disconnection. And there is some evidence emerging, I think, that higher levels of screen time use in certain settings can promote anxiety and depression, but it's kind of mixed at this point. But I will say that the findings that we've seen about physical activity and social support have impacted my clinical practice. These are things that I now routinely refer to because the evidence is really pretty strong for those lifestyle changes. How do you recommend starting to pinpoint and target mechanisms relevant to precision medicine without big data? That's a great question too, and there are ways. So one of the things that is a method or approach in precision medicine that is relatively new is, believe it or not, N of 1 studies, looking at, if you have in that case deep phenotyping data, let's say, you can look at changes that occur for an individual that have large effect sizes on some biomarker or readout. In other areas of medicine, they are doing things in precision medicine that don't necessarily require a lot of data, but are not feasible yet for mental health, and maybe it won't be. For example, gene editing in rare disease. That has been the essence of precision therapeutics for things like, sickle cell anemia, or in genetics, fueling new cancer therapies and so on. Deep phenotyping can be helpful, though, even if you don't have big data. And then there's some controversy about, still, how much data do you need to feel convinced? Another question is, I want to pursue a PhD in clinical psychology, and I'm very interested in precision medicine, but I don't have a lot of machine learning background or AI background. Do you have any recommendations for grad students or researchers who want to do this line of research but don't have a heavy quant background? Yeah, that's a great question. I do think that you don't necessarily need to have a heavy quant background, but a lot of these data-driven approaches do require a familiarity with the structure of how you analyze large-scale data, if we're talking about the big data stuff. So, for example, I, as you might imagine, did not come of age in my training when AI was big. But through working in this field and reading and taking courses and doing the research, that's how I've gotten my sort of background in these areas. I think getting involved, if you're looking for a PhD program, getting involved at a place that does this kind of work and that has access to, pretty good biomedical informatics or computer science or, or precision medicine more generally, through an apprenticeship kind of exposure and coursework, I think you can do it. I mean, we're all kind of learning some of this stuff as it evolves. So it's not like, people have 40 years of experience in large language models. Nobody has that experience.
So I think we have time for that last question.
Great. From Bruce, thank you. You showed early in the talk that genomics suggests there are 5 major dimensions, while the rest of the talk was mostly about single disorders. do you have plans to use the admirable analytics of the single disorders with the dimensions from the genomics? Yes. So I did give one example there of how we use those dimensions to try to find novel treatment targets. Um, and one of the things that we and others are also doing is actually looking at to what degree, for example, in predictive models, do RDoC constructs, which can be extracted also from electronic health records, advance our ability to identify who may need treatment or who would respond to what kind of treatment. Once you have the transdiagnostic dimensional stuff, you can also begin to ask some of these basic biological questions. And again, that's something that we and others have been doing. For example, what is the biology underlying externalizing disorders or externalizing traits versus internalizing traits? And we do see some differences there, both in terms of gene expression and brain tissues where those genes are expressed. You can begin to perhaps help move us beyond the DSM diagnostic category-based drug approval landscape by demonstrating that these things may be targeting the genomics that are transdiagnostic, and a whole variety of other things that we can do to leverage the analytics we've developed in those single disorder ways to now apply them to what we think are more data-driven views of the variation between people.